So for our next speaker, is Dr. Chris Buettner, and he's a pediatrician, clinical investigator, and ethicist at the Children's Hospital of Philadelphia and the University of Pennsylvania, where his primary focus is on improving the lives of children with complex chronic conditions. And Dr. Buettner is also the chief physician in the Division of General Pediatrics at the Children's Hospital of Philadelphia, where he focuses on palliative care and also clinical ethics consultations. He resides outside of Philly with his wife, 3 kids who are now in college, and Rita, an eager morning run canine companion. Please join me in welcoming Dr. Buettner.
Good evening, everyone. Before we get going, if you are a chaplain, can you raise your hand? So for people in Zoom land, almost all the hands are raised. Here is a physician, and I would say there are about 4 or 5, including our other speaker, and who is in either social work, nursing, child life. Oh, okay, so we have that helps me a lot. We can bring up the slide. I am hoping that I'll get the temperature warning. Our goal that I'd like to put out, usually for CME you have to create learning goals, but I actually hope that at the end of this hour, actually 50 minutes, the clock has not started. I'm nervous about the clock, but in 50 minutes, you'll be able to answer what does it mean to get ongoing conversational consent. Anybody already know what that means? Good, no hands went up. I hope to explain it. I have found it to be one of the more potent ways of actually thinking about furthering conversation. And I'll illustrate that and make a point. What your own personal commitments might be. As a chaplain, how are you showing up? What is your side of the bargain that you're offering the people that you are providing pastoral care to?
Excuse me, can you use the hand mics? I think back can hear you. They can hear you in Zoom. Just
What's that?
Can you use the microphone so they can hear you?
Got it. Okay, I apologize for wandering away. I have a habit of wandering off. The third point that I hope to make clear is how we can explore with parents, with family members, even with patients, what their personal sense of duty is. And hopefully, at the end of this time together, you'll have a sense of these 3 things, which will be tools in your toolbox. Not only, okay, I get the purpose of it, but actually, how would I go about it? But I want to start with a story. This story takes me back over 15 years ago. We were starting our palliative care service 20 years ago. And I was being asked as a palliative care doctor to go by the pediatric intensive care team to go talk to Bobby's parents. Bobby was at that point about an 8-year-old boy who had a progressive neurologic deteriorating condition. He had been diagnosed about 8 months after he was born, and it's the kind of relentless, terrible disease process that can affect children, where otherwise healthy-looking child slowly starts to lose the ability to do things, including being able to regulate breathing and the airway with cough and things that you need to do to have healthy lungs. And over time, that had gotten to the point where we had gone not just from a little supplemental oxygen and providing cough assist to having to be on non-invasive ventilation, something that keeps pressure in there and even helps you breathe. But now he had clearly a viral illness, and it was clear that he had already been on the edge of respiratory failure, and he was being pushed hard into respiratory. And the parents had been told this, and they had seen this coming for a long time. He had skirted a couple of times where he had nearly not been able to make just non-invasive respiratory support. And the next step, not that he needed it, but the next step of technological escalation would be to put in an endotracheal tube and intubate him. But they had thought, because they had the other type of goal care compensation, which isn't saved to the very end of life, but is done when the patient has heart failure or has a bad hematologic condition. I'm looking at people in the audience like, you can start to talk about what we are hoping for, what our goals are, well in advance of the final hour. And they had said repeatedly, they didn't want to put in a breathing tube that may never be able to come out. They didn't want him to wind up with a tracheostomy. They didn't want to give him that life to live. But now we have to actually face that. And the unit called me and they said, the parents are just beside themselves. They sort of know, they feel what they feel, but they can't figure out how to move forward. They're totally stuck. Can you come up and talk to them? So long story short, I go into the room, I introduce myself to two lovely parents. They're sitting, it's like this time of evening, and I think it was in the winter, and the windows in our hospital were there, and they were sitting on a bench near the windows. And I came over to that side of the bed, and Bobby was laying in the bed to my right, and they're there to start to talk. We talked about a number of things, and they described it how they knew what they thought was the right thing to do for him, but how can we let him die? Like, before it was academic, it was something we sort of had talked about. Like, how can we do that? And I said, is it okay if I ask you a question? And the dad nodded and the mom nodded. Who's in control of the situation? Are you guys in control? No, I mean, this situation is totally out of control. Then, if I can, you're talking to me as though you're in control. You can't control this. And that's part of what I'm hearing. It's like you're grieving because you can't control what is happening to Bob. And there are things you can control, but the disease, it's the disease that's going to kill him. It's not a decision of the And I probably even said that. You can decide not whether he's going to ultimately survive this episode and live on, because the disease is in control of that. But what you can decide is how he's going to live up to the illness. And I had probably said some other things like, this is going to be hard to talk about. Are you ready for it? And they hung in there and they looked at each other. And they said, we're not in control of this terrible thing that's going on, but we are in control of whether he's going to have a breathing tube. And ultimately, we may need to take it out. We're not. I walked out, I said, I guess we talked about so much. I'm going to step out and go talk to the intensive care. They came out a minute later of the room and said, we're not. Now, what happened in that encounter? There are a lot of things I think we could talk about, communication skills, etc., and that's all good. But I have devoted most of my career to really trying to think about mechanistically what happened. They were stuck psychologically. And there were certain things that we talked about that seemed to help them. One of the things that's very clear is what did not help them was probably a big download of information to inform their prefrontal executive function cortex. A lot of ethics is like informed consent and all that kind of stuff, where you're going to exert your autonomy. Instead, what they were really struggling with is the human aspects of just dealing with all the feelings that they had and not knowing quite what to do with them. In healthcare, I think that the real essential triangle of relationships, the iron triangle, we are always dealing with people who are feeling, thinking, and relating. And we enter into that triangle. We actually participate. In fact, I am sitting there next to Bobby with them, thinking, feeling, and relating. And so are they. And part of what we are trying to figure out is how do we enter into this set of relationships between their thoughts, their feelings, and their relationships, and figure out how do I collaborate in that space. And while I do think communication tips are really helpful, and words, how they are said, tone, pitch, etc., can be helpful, they're just part of a bigger thing going on, which is relationship. And how do you have a relationship, admittedly, over the course of 15 minutes from meeting them to talking about something that was one of the most intimate conversations they probably had ever had about something that was totally out of control. All right, I'm going to take a bit of a risk here. It's more intimate for many people than even having sex. Now, I say that a little bit for the shock value, but we think about sexual relations as being, you have to say no, you have to respect that, you only let certain people in. How many people have had a conversation with a stranger about the life and death of a loved one? Okay, you have. Did that feel like you were vulnerable and it was a very vulnerable? Okay, so the metaphor, and it's a metaphor, is you have to treat it. I do it all the time, but it's not all the time for them. How can I enter into this relationship with things like conversational consent? Is it okay if I ask you a question? Is it okay if we keep talking about this? And you are not saying, I'm not looking forward to this. Nobody ever expects, is it okay if I ask you a question? Like, it's a happy question. No, it's probably going to be a difficult question, so it's a bit of a warning shot. Is it okay if I ask you a question? And if they nod yes, I have conversational consent. Again, analogous to the way that you would think about even having any other type of relationship. Okay? If you understand, we're talking about relationships. So, there are going to be pop quizzes throughout this. There are subtle cues and clues on the slide as to what answer I think is correct. But thinking, feeling, relating, or all of the above. All right, very good. You guys are strict audience. What I think happened, and I think it's important for people who do ethics, and particularly things like normative ethics, and they're all up in their head and thinking about exactly what's the right thing to do. Parents don't just think their way to the right decision. They have to feel it. When my dad was dying, when my mom was dying, two separate, 3 years apart, as an adult child trying to take care of my parents, I not only had to think my way to the right decision, I also had to feel in my bones I was doing right by them. Nobody talked to me about that. Nobody. 2 cancer journeys, one for my father that went on for 6 months, one for my mom and I've written about both of them, for my mom that went on for about 3 months. Nobody asked me, do you feel like you are doing the right thing for your dad? So there's a huge opportunity for us to potentially insert ourselves with permission. How is this feeling for you? And we're going to get back to the sense of duty. That these feelings aren't just about what's best for the child or best for my dad or my mom, but what is also my duty to them. Everybody knows about the best interest standard for children, pediatrics. Yeah. That's the number one thing, right? Yeah. In terms of, it's a great organizing rubric for a lot of pediatric ethics. This is fundamentally different. I remember there was a baby in the critical care, cardiac intensive care unit, very, very ill. I was there as a palliative care doc, and I leaned over the bassinet and I looked at the child and I thought, oh my gosh, what can I do to help this child? What would a good doctor do? But that is different than what is the best thing for this child. Somebody I was talking to earlier who was about to go have a difficult conversation was thinking about, what do I need to do to be a good doctor here? Not only what is best for the patient and this parent, but how do I need to show up to be a good doctor? Or, let's spin it around, to be a good parent, what do I need to do? Many parents are stuck. They already know all the pros and cons about what could be done for the child. For all of you who are taking care of adult children, who are taking care of mom and dad, they're wondering, how can I do that thing they're asking me to do and not feel like I betrayed her or him? And then lastly, relationships can help people when they're stuck in that situation. And there are very specific actions you can take. Now, it's interesting that the concept of space came up in the last talk. I use this as an organizing mnemonic to keep myself organized. If I'm in the room and I'm looking at Ron and I'm talking to you, there is a ceiling above us. Pretty much I've never been out in the open field, so maybe the ceiling above, a floor below, there's a wall behind typically, and a wall behind me. Now, the way I'm thinking of it is actually that's your forward wall, so I'm taking your perspective. So there are a couple of things that we can do in this. One is we can continue to try to get you to move as a decision maker with what I call the bulldozer of medical information. Has anybody seen the bulldozer of medical information in action? Have we talked about how this won't work for the 50th time and just trying to convince people that they are making the wrong decision by providing more and more information? That's the back wall trying to press you into coming in my direction. Usually I'm involved in care and I say, can we just stop doing that? Please, give me 48 hours. I've been asked to go to the NICU, the patient's been there for 9 months. Can we get the DNR conversation like tomorrow? I'm like, no, give me a week and stop bugging the parents. Give me a week. So I stop the back wall from pushing, because the more that happens, you don't have space to make a decision. Then we're going to have to talk about a couple of things. One, the language of hope, which I've written about. What are you hoping for? And I'm not going to be able to go into this in great detail, and there are hopes. It's not one monolithic thing of cure. Even when people say, I'm hoping my child can be cured, that is almost always the first thing that comes out of people's mouths. I honor that. I respect it. I empathize with it. What good parent would not say that? And what else do you hope? And very often, there are other hopes. Well, I'm hoping when the time comes, he doesn't suffer. What are you worried about? The things that are weighing down people. What has you scared? I talk to parents about, is it okay if we talk about something? Have you wondered what it will be like when he dies? Talk about a third rail. But I've not had parents freak out on me when I've asked them. They usually get a bug-eyed look and like, I'm terrified of that. I can't even begin to, I think about it and I have intrusive thoughts about it, but nobody's ever talked to me about what that might look like. Gently, can we talk about what that would look like? Because if they're being pressed down by unstated worries that they're not sharing with people out of relationship, they don't have any relational support, not just being bereavement, even in this part, they need support. They're doing it on their own. And then can we talk about the floor that you are standing on of what you think you need to do to be a good dad? I've studied all this in the mix of terminal. All the research I've done with parents who still have their children very much alive, often in danger of illness. And it just changes the way that they think about their options. Right, but before I go any further, I should probably introduce myself more than I did 20 minutes ago. So if I were meeting you for the first time, good to meet you. I'm going to be taking care of your son or daughter. I'm Chris Beaver. A couple of things to know about me. I'm very straightforward. I'll tell you what I'm thinking. I'm going to tell you how worried I am. I'll tell you if I promise you, I'll tell you if I'm worried. And I'm not going to make a promise I can't keep. I've done this for 15 years. I've never had a parent say, nope, don't want that. We use euphemisms, beat around the bush. We prefer to be confused. Over half the time, explicitly, they say that's exactly what we want. And that just changes everything because I can go back to that. I wish I didn't have to talk to you about this, but I promised you I would tell you if I was worried, and I'm worried. I talked with somebody again earlier. You can do this difficult work in partnership with parents because when they say that's exactly what we want, we're collaborating. Just like you nodding, is it okay if I ask a question? Conversational consent, not informed written consent, but it's a very powerful way of starting to collaborate. Put up your side of the deal, see what they have to say. Quiz question. We talk about uncertainty a lot. There's so much uncertainty in making the medical intensive care unit and our pediatric when trying to collaborate with people for these difficult decisions. What is the main thing? If they're unsure, am I unsure how the parents are going to receive my efforts? I'm uncertain whether I'm going to know enough to guide them. I'm concerned about how other clinicians are going to look at me. Like maybe the head of the ethics committee is going to look over my shoulder and think, he doesn't really know what he's doing, does he? Or all of the above. We did a study of oncology where we actually looked at the 7 types of uncertainty when clinicians care for pediatric patients with advanced cancer. They were not uncertain about the prognosis most of the time. They knew it was really, really a bad situation. Exactly when things would happen, no, nobody ever knows that, but that was not what was giving them pause. It was the social dynamic of how they were relating to the family. Is the family going to go off and want a second opinion? Are they going to leave? What are my colleagues going to think? That's actually what's slowing people down. It's the almost not even the relationship with the family, it's the friendly fire of doubt that I'm going to get criticized by my colleagues. And we don't pay attention to that. It's a huge opportunity in healthcare to actually think about how you as chaplains can even empower people by maybe you can talk to your colleagues. And I see it in the cardiac intensive care unit all the time. Let's all get together and agree that nobody's going to go gangsta on somebody who says, I think we should stop escalating. If we pick on each other, we're just going to have the behavior that we see, that endless bypass. The person who actually pauses and asks the family, do you think we should continue? If they get criticized by their superiors, they're going to learn the lesson. Next time it's just bypass. So mental model check. Now I got to hit the pace up here. I love the graphic. Who did the graphic?
Graphic people.
The graphic. Well, it's called graphic. Maybe that graphic and then last name people. Graphic. She did a great job. But I'm going to pick on him a little bit. Only because I think it's great to have an explicit model to actually help you think about things. Who are they? In the difficult conversations, I think the thought was that they are the patient and the doctor. But as I just emphasized, many of these difficult conversations are actually within the team. In most of my ethics consults, we cleaned up 90% of the problems by having a team meeting where doctors needed to talk to doctors and hash it out. And then usually the social workers and nurses, finally. What does the string between them represent? Is this just information? And categorically, it can't be just information. It also has to be emotion. So what do you think are the best strategies for actually accomplishing all this, collaboration decision-making? How about shared decision-making? Anybody into shared decision-making? Okay, there's an arm that goes up. Okay, good. We have fans. It's certainly better than the paternalistic, we're not going to tell you anything, we're going to mislead you, we're going to give you placebos, or we're not going to tell you about the cancer. Like, okay, no, none of that should be done. But I do think, while it is an appropriate corrective, it has also become, like goals of care, something that we sort of understand and it sounds good, but people really don't know how to operationalize it. And there's a lot of misunderstanding about what it might mean. Is it somehow we're going to find a balancing point between your interests and your point of view and our point of view? Is it actually a way of having a tug of war? And I'm going to do shared decision making until you agree with me? We actually, Sarah Eaton led the study. We actually had a bunch of 21 experts, pretty high caliber ethicists, do a Delphi process to even understand what are the component processes. So I can't compete with Jackie's wonderful diagram, but I will show you something very small and illegible. Here are on the left-hand side all the possible things that you might do as part of a shared decision-making process. We did a lot of interviews with people to come up with the exhaustive list of everything that might be part of that. And then we had them rate them. And the score goes from 9 all the way down to 1. We're not going to show, because very few things got scored that low. 9 would mean if the dot and there's no green line, everybody, all 21 said that's important, 9 out of 9. If there's a little green line, it means that at least somebody voted it as low as a 7. And if the dot isn't on the 9, it means the average was an 8, and one of those is even a 7. Okay? So that's showing you that even though these you would think would all be sort of sorted out, experts do not agree about what needs to be part of shared decision making. Interesting things like, shouldn't we figure out what the ethically appropriate treatment options are up front? No. You don't need to really do that, according to at least some of the experts. What about seeing if the family has preferences about the information that they want? No, you can skip that part. What about things like whether the treatment option recommendations should be offered? A surprisingly controversial topic, which I think is ridiculous. It's our job to make recommendations. People do not need to accept them. But to think that this is just a restaurant, here's the menu, and well, what would you recommend? No, sir, I make no recommendations. I don't want to be paternalistic. I mean, that waiter's not getting a tip. Even things like sub-processes on how directed. So the point that I'm making here, in your typically abstruse academic way, is that even experts on something that has become a bit of a shibboleth, like we all agree in shared decision making, but I bet you our mental model of what it means is different in key important ways. So we're all agreeing for something that we don't understand. There's a lot of opportunity here for people to clean this up. Okay, so shared decision making, standard stepwise process, a panacea for preventing conflict, a solid prevention against bias, a fuzzy ideal that provides guidance but creates confusion. That I think is a fair summary of where we are. I'm not here to sugarcoat it. I'm just here to say I think we headed in the right direction, but we are now sort of comfortable with the ambiguity, and I'm not sure that actually helps patients. What about goals of care discussions, as was picked up from the last talk? We studied over 680 parents of children who had palliative care service were being provided, a very, very large cohort study that we conducted. And we had them do something, I won't go into the details, where they could rank these 5 goals of care: seeking quality of life, health, comfort for the child, disease reduction, or longer life. And these are the relative importance of those 5 items across the whole sample. So what this is saying is that the number one highest rated goal was seeking quality of life. The box is where most of the scores were, and the vertical line in the box is the average score, the median. Next is seeking help. Now, I have a lot of people like, wait a second, the kid's getting palliative care, they're not healthy. Like, have you ever met a parent who says, I'm okay if you ignore my child's health? Have you ever met a parent like that? And yet I have ICU doctors who are like, oh, we don't have to worry about things like vaccines or because the kid's, he's being. No, that will really irritate parents. They are obliged, they have a sense of duty to make sure that their child's health is being protected, along with their quality of life. Comfort, which many teams are like, we're the comfort team, has become another one of these buzzwords that actually, who's against comfort, except when it's a code word for we're not actually going to do everything. And then disease reduction and seeking longer life. But notice the variation. So there are people on the lowest ranking one who actually ranked it by far the highest. So when you talk to people, if you ask them, I've talked to many parents, and some parents they think the most important thing is their child's quality of life. Or maybe it's their child's health. Or maybe it's their child's comfort. Or maybe it's how long the child will live. Disease reduction is really specific to cancer. Any of that speak to you? And this is a technique we're going to do when we get to parental sensitivity. You might find that they suddenly light up with one of them, like that's our most important thing. And you can do this early days, way before you get into an period. What you then need to do, which is often absent, given that goal, if your goal is really quality of life, would a tracheostomy fit in that goal? Now, I wouldn't do that now, but that's the missing link, is that we assume the goal is a care conversation. We'll get to the point where Bobby's family was staring down the end of the decision where if we don't intubate, that shorter life thing is going to happen, even if we think it's helping his quality of life. And that's where we have not closed the loop. They had their goals, but they hadn't actually come to the bitter trade-off that life is forcing on them of having to pick one of them over the other. So, again, you're getting the theme here of these top quizzes. All parents prioritize the same goals. So we don't really need to talk about this much because we're busy. We're in the intensive care unit. We got to move through the day. They prioritize only one goal, or they prioritize a set of goals that sometimes are even in conflict with each other. Like if I prioritize quality of life and life prolongation, I'm cool with that. But I do see that there might be some challenges for you ahead with tracheostomy decision, especially if your child cannot tolerate anything up around their head. Case I was dealing with just last week. So gently actually pointing out with validation of their goals of some of the challenges that they're likely to face down the road. And down the road might mean tomorrow. Other things I'm going to breeze through. Goals change over time. This is actually how long since they've initiated palliative care. You can see the longer they're in palliative care, particularly the issue of comfort becomes more important the longer you're in, and some of the other goals ease off. Equally important is how often they change what their top goal is. So if I've had a conversation with you today, what this is saying, if I revisit that goal conversation in 2 months, which is 2 months, but it's not 5 years, there's a 40% chance you'll change your top goal. So a goal of care conversation has a time stamp. Either because circumstances are changing, or because they're learning, or they're just in a different place. All right, I'm going to skip over. What other strategies could we pursue? The other party's personal sensitivity. So I've highlighted that a little bit about parents asking themselves, what should I do to be a good parent? It's not the best medical decision. It's not what does this child need. although it's related to that. It's related to that. So you as pastoral counselors are particularly well positioned to talk about what the decision maker who you may be talking to chiefly, what do you need to feel like you can do for your loved one? Doctors stink at this conversation. I mean, have any of you walked in and seen a doctor having a great conversation with a surrogate decision maker? I mean, maybe I'm not in the conversation, but I've walked in on many chaplains. First chaplain I collaborated with, Martha Dimmer, when I was in Seattle Children's as a resident and started a child care program there. I stopped her one day and I said, I notice you're walking out a lot of rooms I'm walking in, or the other way around. I think we should meet and have coffee. Because that availability that you have at the bedside to family is incredibly important. And they're looking for some guidance as to how can we be good people doing this job of having to make the decisions for our well. All right. Because I do what I do, I studied this, 200 parents, 158 kids, where we actually asked them, what do you think you need to do to be a good parent? You can read about it. Here were the set of possibilities. Advocating for my child, focusing on my child, having as long a life as possible, the kid's comfort, the kid's health, quality of life, spiritual well-being. I'll say in this room, yay, spiritual well-being. Outlook needs to be positive, outlook needs to be realistic, making informed medical decisions, making sure my child feels loved, putting the child's needs above my own, staying at my child's side. Now, who, as a parent here, is willing to say, which of these speak to you as a parent? This is not how we did the exercise, but if you had a seriously ill child, which of these do you think you would feel you need to do? Okay, you're saying something, but I can't hear you.
Advocating.
Advocating, thank you for that.
Making sure they feel loved.
Making sure the child feels loved, thank you for that.
Being present with the child during their time of need as they go through this process.
Thank you for that.
Quality of life.
What's that?
Quality of life.
Quality of life, thank you for that. Anybody else? Come on, somebody over here.
And said advocating also.
What's that?
I would also advocate.
Advocate, okay. Any of those bad answers? No. Or are they all the same answer? If I'm talking to you about advocating and I'm talking to you about love, maybe I should know that you may be struggling with different things, what it looks like to be a good advocate. Are you effective in it? And you may have a backstory. In pediatrics, there's often, like I've learned, I have to be an advocate for my child with special needs. Versus I feel I need to make sure my child feels loved. Versus people who need to stay at their child's side, but because of work obligations feel like they're failing because we're going to get thrown out of our house if we don't make rent. I got to keep working. So here's what the sort of the group average was. The most highly rated item was make sure my child feels loved. I guess in this room, I should have thought more about putting the slide up. At the bottom is safeguarding my child's spiritual well-being. And I think it's actually because when I've talked to parents about this, they don't think that that is a duty that they have to worry about. That is being done already. So it does not mean that they don't care about this, but it's almost like somebody else, either a higher power or other members of my community have that, and that is not falling on my shoulders. But for some it was. Again, notice the variation here. The biggest mistake I made in publishing, this probably should not have been the graphic I showed. Because people, making sure your child feels loved is the number one thing. That's not the point. The point is, I am not a mind reader. You could have said love, and you could have said advocacy. Unless I ask the question. I've talked to many parents, and often they have an inner sense of what they need to do to be a good parent for their child. Now, sometimes it's about advocating, sometimes it's about being at the kid's side, sometimes it's about making sure the child feels loved. What do you feel you need to do? That opens up a door to a set of conversations completely different than practically any other question I've ever asked. And then I can hear what they have to say and ask, how can I help you in doing that? So, they don't all prioritize the same thing. They only have one thing, nope. They often are prioritizing a couple of different goals. That they feel their own ethical duty around which they would build a case for what they are obligated to do. And if you can open up that door, you have a lot of room to help them. You can also explore their sense of the situation, their SOS. I'm not going to go into this, but if you want to read about it, you can read about it. The problem is that medical problems are a large part of the problem, including, as we have shown, financial distress. So those are symptom scores of the child getting palliative care. And on the right are their feeling of this is their parent's distress and the total symptom score. But the thing that really drove at least half of the distress score of the parents is their financial distress. So when we're talking to people and they're really upset, it is clearly the loved one, and there may be other things that are going on that need to be addressed. And that's part of their problem set, and probably we're part of the problem. So often, I often talk to parents, I'm like, I'm sorry, I know I'm part of the problem. We, the medical profession, how we hand off, and we're not always as clear as we could be, of helping people think, how are they going to navigate? And not navigate, from some perspective on high, but like this. They're trying to figure out, I'm lost in one of these mazes. And it's very disorienting. So let me give you some practical recommendations. And we'll run through these 6. First thing, as I already did, is really try to think about how do we open up the possibility. Like I'm inviting you to partner with me. Here's how I'm actually going to conduct myself. I'll come to that in the next. Is it okay if I ask a question? These kind of invitations to go to the next level of the relationship are an invitation to collaborate. If you're curious about how this would work in more detail than I can present today, I wrote a whole book about it. I will tell you one little vignette from this book about a chapter, so it's 12 chapters going through the life of an intern who's gradually learning to do more and more. And this story called Mortal Choices occurs in April of that intern year, where Reggie, all fictional, a high school senior, has been in a terrible MVA and has had a traumatic brain injury. Rob, who is the protagonist, is caring for Reggie. Rob has several discussions with Reggie's dad over the course of a night or two, really outlining how bad things are and helping his dad start to mobilize, his resources. Reggie's brother, Ed, a college student, arrives at the hospital late the following night, and at the dad's urging, Ed is asked to talk with Rob. What should we do? Ed asked, the firmness back in his voice. Someone must have said something to my dad about putting in a breathing tube in his neck and feeding him a tube in his stomach. My dad's tearing himself up. I get why. How can anyone make a decision like that? I thought a lot about medical ethics, advanced directives, substitute judgment. Did you and Reggie ever talk about anything like that? No, we were tight, but we only talked about sports, school, friends, things like that. Nothing like this ever came up. drawing a blank, I retreated back. It's everything I had seen and been part of this past year. Something bubbled up, an idea of a question, a feeling of something deep and fundamental. May I ask you a question? It's not an easy question. You nodded yes. If the situation was reversed, what would you want Rachel to do for you? And sat up straighter, peered at me, and said nothing. I already outlined sort of the 3 prompts that I made. And, you know, I have to admit, being an utter failure of convincing anybody I work with to do likewise, they just feel it's not their thing. And why they won't is a little bit baffling to me because it is, for me, has been such a powerful way to connect with people and figure out how to establish a relationship quickly. You don't need to have these in your explicit promises, but, you know, back in the 90s and 2000s, people were like, I have to explain my philosophy of care. This is actually the manifestation. This is actually how I want to have our relationship. You can talk about hopes and fears again in the space metaphor. Can you help me understand from your point of view what's going on? That's the situational understanding, the SME. Given what your child is up against, what you're hoping for, what scares you. And again, I a bit about this too. We can discuss parental duties. Again, I talk to many parents, and I know they often have carried around in themselves something that they don't talk about much, what they need to do to be a good parent. I've sat at the bedside of many older parents and talked to their adult kids. And they often have a sense of what they need to do to be a good kid. What would that mean for you, your mom, dad? Again, if you want, you can use this mnemonic. What are the worries that are weighing them down? What's the path forward, their hopes? What is their foundational sense of duty? You have to figure out how you're going to manage emotions. And one of the things that I talk about a lot is like just how sad the situation is, to name it, to tame it, and how angry I feel about the fact that Bobby had that condition. It's terrible. At the same time, I have to manage my own emotions. Again, one of the things CPCB, I know, teaches a lot of how to actually be present in the midst of suffering. I do a lot of things, including on Len, just to help me be fully present without running around feeling the need to do things. It's a meditation practice. And in a crazy situation where I was with my dad when he aspirated, and everybody around me went batshit crazy while I sat there holding his hand while he was dying, and they wanted to get 911 involved, even though he had an advance directive that said do not do anything. I'm very grateful for that practice because I actually was with him. You also can think about how you're working with other heuristics, including things like re-rolling, which is basically, I've heard you mention several hopes. I wish I could help you with that one. You did mention something that maybe I can help. The final quiz, what do emotions, hope, and love and relationships have to do with medical decision making and collaborating? A lot more than we have talked about. And I hope that this time together is giving you a couple of things, particularly, may I ask you a question? Repeat after me. May I ask you a question? Gold. Another gold is, I wish the news was different. The breaking down. But can I ask you a question? It's huge. And you can think about your promises that you may want to extend to people, and think about asking them whether they carry around a sense of what they feel that they need to do. Are they willing to share that with you? Thank you very much.
I was wondering if you could talk about a situation where a parent would be like unwilling or hesitant to give conversational consent, and like how you operate, how you
So like role play. Are you willing? There's something I think we should talk about. You willing to talk about it now?
No, I'm not in a good space right now.
Yeah, I totally get it. We'll come back. Now, suppose I had not done that. Let's just play this out. And I barge in and I said, well, we need to talk about DNR data. How's that conversation go? I'm Ron, you say you're I'm a pragmatic idealist. Like, that ain't going to go nowhere. So did I lose anything by giving you control over that situation? No.
Okay.
What I have found is probably if I'm on the unit and I come back around, within 24 hours, you're going to say, I'm ready. I've never had a parent where I've used that technique. I've had parents who know they just want to do this. And I'm not going to probably use that technique. I'll do other things. But I've never had a parent who has not proactively almost thought me out and said, I'm ready. I was not ready yesterday. Today I'm ready. And the conversation, I think, is 100% better. Thank you for asking.
Have you ever had a situation where, and I'm thinking about with a child that maybe is a little bit older, so thus has some kind of understanding about their current situation, and they've expressed, to medical professionals, maybe even to the hospital social worker, of I'm tired of fighting, or I want this for myself. And you go and have that hard conversation with the parent and they say they're a child, they don't get to make the decision. How do you deal with that disconnect with both, validating the child, but also understanding, yes, the parents do have that lead. How do you have that type of conversation?
Yep. What did I say? I promised you I'd be very straightforward. So I hear you, I respect you. I also need to figure out, because I have a sense of duty that your child is telling me things. So I don't need to follow their guidance, but I do need to figure out a way that we're going to talk to them so that they don't feel isolated or like we're just not paying attention. I don't know about you. I suspect you even think I'm probably not going to help them. So you do need to know where the rubber hits the road, and on decision making for treatment decisions until the child is an adult. Like I almost wish Bill Bartholomew, may he rest in peace. I love the guy. It gave us a sense that we could respect children above what we actually are legally allowed to do. So unless I can do that and go all the way, I'm very careful in the assent realm of age to not overpromise. I'm going to try to take your factors. Now I respect them. So that's where I start to then haggle out a deal. I do it in as straightforward manner as I can. And I can also be firm on my thing. And not that about it, but like, how do we find a way to work? You have the sense of what's right for your care. You're worried if we talk about this that they're going to get hurt. There may be ways that we can work that. That can be a tricky space.
Thank you
Clock
so
is
much.
telling me the time is out. Thank you very much.